Okay, that took longer than it should.
Yeah.
What's
4 years old? I don't know.
the screen on that is really good.
That's cracked. Thanks.
Right?
I'm putting under my 2 fingers.
Which school? You're in the choir?
I don't know for school.
You're in the jazz band, so you're going to. Greg, Crump, he's in the jazz band. Thank you. You guys are heading to Grand Rapids and all that. It's very well. It's called that. Okay, class. You're in the jazz band too?
No.
That's it. Yeah. No. All right. I really want to keep my promise to you. If the weather gets nice, we'll meet outside. It's cold out there. Can I get an amen? It's the end of August. I'm done with this. Yeah. Sorry. That too. Yeah. End of April. I'm so done with this. Yeah, I'd be really sad. Yeah. So another month that starts with A, and I just, yeah, I've had enough, completely enough. So, okay, we have some people out sick, unfortunately. So please do your best to stay healthy. This stick student said, I'm going to really try to come to class, which I said, no, stay away. So hopefully she'll join us on Zoom here pretty soon. We are talking about diabetes mellitus. Who can tell me the difference between diabetes mellitus and diabetes insipidus? They do in mellitus too, if it's not treated.
Yeah, but just like.
The pathophysiology is different, yeah. Yeah. What's the, Brooke, you had your hand up?
Well, I don't know which one's which, but I know one is that your insulin, something insulin that perceives or your insulin receptors don't work properly, and the other one is
That's type 1 and type 2 diabetes.
Okay,
You're
that's what I was
describing. Diabetes insipidus is due to an inability to make antidiuretic hormone. It's usually due to damage to the posterior pituitary. Strokes can cause this, so can aneurysms, baryaneurysms of the circle of Willis that damage the posterior pituitary. Tumors of the pituitary may also affect the posterior pituitary such that you do not make any ADH. ADH is available as a nasal spray, so that particular condition is very treatable. Without antidiuretic hormone, you can lose enormous amounts of water, and that condition can be, of course, very serious. We're talking about diabetes mellitus, where the body either does not make sufficient insulin because of damage to the beta cells, that's type 1, or insulin resistance. The hallmark of of type 2 diabetes is insulin resistance. And we looked a bit at the normal fasting glucose should be around about 100. If it's above 104 and between 126 milligrams per deciliter, you are in the pre-diabetic range. Define for me a fasting glucose. 12 hours without eating for an oral glucose tolerance test. Usually if you're taking a fasting glucose, you have to be fasted at least 4 hours at the very minimum. For a gestational diabetes oral glucose tolerance test, they'll usually ask you to fast 8 hours. But usually the standard is 12 hours, typically. And with these sorts of tests, people will say, well, do I have to sit here for 2 hours? Usually the text will say, no, you can go out and walk around if you want. Just make sure you're back here in time for your readings. So the oral glucose tolerance test. And we saw that the people who should be treated are anybody over 45. So when you get your blood draw for your physical, a blood glucose level is one of the things that will be tested. If individuals are obese or they have a first-degree relative with diabetes mellitus, there are some ethnic groups that are higher risk. So Latin Americans tend to be at higher risk. African Americans, if they're descended from West Africa, are at higher risk. And then anybody really who has a relative, first-degree relative with diabetes mellitus is at increased risk. History of gestational diabetes or anyone who delivered a baby greater than 9 pounds, which is a toddler at birth, frankly. But typically diabetics, because the baby grows so much during those last couple of weeks, diabetics will tend to have large babies because high blood sugar causes the baby to grow even greater. And then anyone with hypertension should be tested as well. So the goals for someone with diabetes is a preprandial glucose. What does that mean, preprandial? Before a meal. Very good, Reed. Well done. Pat yourself on the back. Postprandial means after a meal. After a meal, at least 2 hours after a meal. Preprandial is before a meal. So you want to try to shoot for 80 to 120 mg per deciliter. Bedtime glucose, you want that to be a tad higher because You won't be eating when you're at bed, go to bed, and your glucose will get lower. You want that between 100 and 140 mg per deciliter. And then there's this number called the hemoglobin A1C. The hemoglobin A1C is glycated hemoglobin. Glycated hemoglobin. When you have high amounts of sugar in your blood on a regular basis, sugar is an energetically rich molecule. It can react with tissues around your body. One of the molecules it can react with is hemoglobin. So measuring the amount of hemoglobin that has glucose non-enzymatically attached to it will tell you how much damage the high glucose levels are doing to your body. This number typically doesn't lie. Someone tells you, oh, my blood glucose control has been fantastic, and then their A1C is pretty high, that tells you they are not telling you the truth. So this is a good measure essentially for how well you have controlled your blood glucose. You want, your goal for diabetic is for your A1C to be below 7%. Below 7%. So a non-diabetic would usually have an A1C usually in the 3% range. So for diabetics, you want it below 7%. So type 1 diabetics have damaged beta cells, so they're insulin deficient. This tends to come on usually when people are younger. And your type 1 diabetics on the average will usually be kind of lean. Simply because the deposition of fat requires insulin. If you don't have sufficient insulin, your tendency to gain weight tends to be low. Again, there are exceptions, but this is what you see on the average. So their treatment for all diabetes is diet and exercise. Diet because you want to have a diet plan that is rich in proteins and tends to go lighter on the carbohydrates. Exercise because exercise sensitizes tissues to insulin. Lots of research on that. It's true no matter what. For type 2 diabetics, they will tend to be older, albeit we're seeing type 2 diabetes in younger and younger and younger people. They will tend to be heavier, and they're insulin resistant. They will tend to make higher than normal levels of insulin. Their treatment is diet and exercise. They may need insulin, depending on the nature of their condition, but they'll usually take medicines that will improve the insulin sensitivity of their tissues, or drugs that will increase the amount of insulin the beta cells make. The variety of drugs, we'll take a look at the whole kit and caboodle of them. Let me just say, since all of you will be practicing nurses, God willing, diabetes education and diabetes management is a huge growing field among nursing. And if any of you have an interest in this field, you can get a job pretty near anywhere. If you want to do diabetes management, diabetes education, anything like that. Also, if you work in the school system, diabetes education is really going to be huge. Simply because it's becoming a bit of an epidemic in this country. So that will be something you will deal with quite a bit if you want to be, say, a school nurse or something like that. So type 1, you really have to watch your carbohydrates. In fact, you have to count your carbohydrates. Meals have to be scheduled. You can't skip them. You want to try to minimize the big swings in blood glucose. With constant glucose monitors, that's easier to do now than it used to be. Constant glucose monitors that are integrated into cell phones, like the Medtronic or the Dexcom systems, can tell you what your blood glucose is on a minute by minute, second by second even basis. It even tells you which direction your blood glucose is heading. Is it going up or is it going down? Very useful. And it's clear that by minimizing the swings, you decrease the tendency for complications. Most type 1 diabetics nowadays will use pumps. There are people who don't want pumps because some people feel that a pump allows them to eat whatever they want and they'll put on more weight that way. That is a concern. That is a concern. With the pumps, however, come the constant glucose monitors and the ability essentially to use an artificial intelligence program to actually adjust. The pump almost works like an artificial pancreas now. Instead of you having to program into the pump precisely how much insulin you need, the pump can actually detect what your needs are and adjust the insulin accordingly. Now for meals, you'll still have to program that in. You used to have to take the pump and do that. Now you can pull out your phone and you can program it on your phone. The technology is remarkable nowadays, but it means that diabetics more than ever can live normal lives. One of the biggies with diabetic kids, you want to maintain normal growth. You also want to maintain normal activity. You have a diabetic kid and they want to play soccer, make it happen. Don't say, no, you're diabetic, you never use diabetes as a crutch. There are a lot of diabetic athletes. They're professional athletes who are type 1 diabetics. You just have to learn to manage it, and you have to learn to manage it carefully. Type 2 diabetics. Achieving and maintain weight loss goals is really big because the more weight they lose, the easier it will be to control their diabetes. In fact, if they lose enough weight, their dependence on medication may go away, and they may be able to control the condition solely with diet and exercise. So you want to maintain an optimal blood glucose level, optimal serum lipids, and blood pressure, all very important. You want to increase physical activity, even a little bit. Increasing physical activity can pay big dividends again, because exercise sensitizes tissues to insulin. You have to watch the types of foods that you eat. Oh, it's low sugar. Well, what else is in it? Is it high fat? If that's the case, then you just have to try something else. Now, it doesn't mean that you can never live a life and never eat anything that tastes good ever again, and you're on the Pritikin diet the rest of your life, so to speak. You guys are too young to know what that means. But it does mean you have to be careful and you have to be sensible. We'll cover type 2 diabetes drugs first, then we'll talk about the insulins. So the type 2 diabetic drugs include drugs that increase insulin production. Those are called secretagogues. Secretagogues. So those include sulfonylureas, which are older drugs, but are very, very inexpensive and are still used today. Meglitinides, which have very short half-lives and work a lot like sulfonylureas, are not used quite so much anymore today. Then there are insulin sensitizers that sensitize tissues to insulin, like guanides. which includes the very important drug metformin, which is first line for type 2 diabetes, and then the thiazolidinediones. Oh, mercy, who names these things? We're just going to call those the TZDs, shall we? Because thiazolidinedione really doesn't roll off the tongue, does it? No. So let's just call them either TZDs or something like that. Then there are drugs that decrease glucose absorption. Those are the alpha glucosidases. Alpha glucosidases. Those should probably be alpha glucosidase inhibitors, actually, is what they should be called. Then you have the dipeptidyl peptidase 4 inhibitors and the incretin mimics, and then the sodium glucose transporter 2 inhibitors, the SGLT2 inhibitors. So let's take a look at each of these particular drugs in order. First of all, are there any questions about diabetes, anything like that? No. Sulfonylureas. Sulfonylureas used to be a big, big class of drugs. Now there's really only 3 that remain on the market. And so there's 3. There is glipizide, glyburide, and glimepiride. Or excuse me, glimepiride. So in the beta cell, you have calcium and potassium channels in the membrane. Typically, the potassium ion channels are open. That allows potassium to leak from the beta cell. And the calcium channels are normally closed. So if we were to draw ye holy beta cell, use your imagination, pretend that's beta cell. There's your potassium channel, and your potassium channel is open. And then your calcium channel, and it is closed. Now, if glucose is present in the blood, it will get transported into the beta cell via a facilitated diffusion transporter called the GLUT2 transporter, and then it gets metabolized into ATP. So let's put a there's GLUT2. Let's say this is glucose. That's going to come into the cell. It gets metabolized by glycolysis. And glycolysis degrades it to pyruvate, NADH, and ATP. So, amount of ATP in the cell depends on the amount of glucose in the blood. Okay, with me so far? Yes? These potassium channels normally are quite sensitive to ATP. So they're called ATP sensitive potassium channels. When the ATP levels inside the cell increase from the breakdown of glucose, the potassium channels are going to close. and then these will close shut. Now it's closed. So more ATP, potassium channels close. The potassium channels in the beta cells are ATP sensitive. They close when the beta cell takes up glucose. When's the beta cell take up glucose? When there's glucose in the blood. So now the concentration of potassium inside the beta cell is going to increase. This depolarizes the cell. The depolarization of the cell causes the calcium channel to open because that's a voltage gated calcium channel. Calcium enters the cell. What happens to neurons when calcium enters the cell? The action potential gets to the axon terminus. There's a voltage gated calcium channel there. Calcium enters the cell, and then all those vesicles filled with neurotransmitter, what do? So ye holy neuron. Your action potential is to here. Your voltage gated calcium channel opens. Calcium comes into the cell. You get all these vesicles laden with neurotransmitters. Calcium comes in and the vesicles fuse with the membrane, and they dump their neurotransmitters out into the synaptic cleft. Yes? Yes. And in fact, the drug we talked about, gabapentin, that's how gabapentin works. Gabapentin inhibits that channel. That's why it's so good for neuropathic pain. So, what happens when calcium comes into the beta cell? It's got all these vesicles filled with insulin. What does it do? Say it again, May. It dumps its vesicles and dumps insulin into the bloodstream. Exactly right. Exactly right. So glucose comes in, ATP inhibits the potassium channel, cell depolarizes, calcium comes in, and the vesicles now full of insulin get dumped. And that's essentially how the beta cell secretes insulin. Sulfonylureas are going to bind to the potassium channel, and they're going to make it super sensitive to ATP. Because this becomes super sensitive to ATP, the beta cell now releases even more insulin. So that's why it is a secretagogue. It increases the amount of insulin that's released from the beta cell. Now, some of you are looking at me as if to say, this is a really dirty trick to play on us this late at night. Cell biology and all this stuff, but that's how these drugs work. The secretagogues increase the insulin released by the beta cells. These drugs are oral, they're old, so they're very well understood and very inexpensive. Very inexpensive. The common side effects of sulfonylureas is that they can cause hypoglycemia. You get all this insulin release, and so your blood sugar now drops like a rock. They also cause weight gain because insulin causes you to make fat, so you gain weight. They can also disturb your GI tract. Some people, they get a bit of an upset stomach with it. It's usually not bad, but some people talk about a sour stomach. Some people do become nauseous, but it's usually tolerated. It can also increase your sensitivity to the sun, so you get sunburned more easily. Some people can get rashes and itching as a result of the drugs. There are reports of Stevens-Johnson syndrome that we talked about with sulfonylureas. That's not common, but it does happen. These drugs also don't mix so well with alcohol. And to decrease nausea with these drugs, you can take them with food that will tend to decrease the nausea. Any questions about sulfonylureas? Let's talk about the meglitinides. There are two meglitinides. Notice that they both end in glyinide, repaglinide, and nataglinide. Repaglinide goes by the trade name Prendin. Nataglinide goes by the trade name Starlix, albeit they're both in generics. These have very short duration of activity. Consequently, they tend to be pretty well tolerated. Severe adverse effects might include hypoglycemia. Pancreatitis has been reported, but it's rare. There are people who are allergic to these drugs, so anaphylaxis can be a problem too. Uncommonly, some people can get flu-like symptoms, upper respiratory infection-like symptoms, back pain. Those are not at all common, but they've been reported. So these work the same way as sulfonylureas. They pick on that ATP-dependent potassium channel, making it really sensitive to ATP so that you release even more insulin. And this picture, I think you'll agree, is much nicer than my monstrosity up here. Let's talk about the signs and symptoms of hypoglycemia, since that is a common side effect of these two types of medications. If your blood sugar usually gets around 60, and then starts to go below, you are usually going to start to get some sort of tingling in your hands and maybe also in your lips. You may get severe hunger and shakiness. Tachycardia is a definite sign. And if someone's on beta blockers will hide the tachycardia caused by hypoglycemia. Pallor and sweating are another set of signs of this mild hypoglycemia. What to do if someone has this? Diabetics should carry glucose tabs. They can pop a glucose tab in their mouth. That will usually help. They can eat a box of raisins. That'll work too. Glass of milk will take a little longer to work, but that will usually raise it to where it needs to be. or a half cup of fruit juice. The fruit juice is really convenient because it's usually widely available and it tends to work quite fast. Moderate hypoglycemia, if your blood sugar gets to 40 mg per deciliter or below. Now you'll start to have an inability to concentrate, confusion, slurred speech, behavior that makes little sense, slowed reaction time, blurred vision, extreme fatigue. Those are all signs of moderate hypoglycemia. A glass of juice will usually set that right, but you must wait 30 minutes before resuming activity.
Why is it 13 minutes?
Did I say 15? 13? I thought I said 30.
Oh, sorry.
30, 30. I said 13? Oh, okay. What did I say over here? 13? Oh, 30. 30. It's my California accent. 30. If someone is prone to hypoglycemia, they can carry a glucagon shot, and glucagon will raise their blood sugar. Warning, after a glucagon shot, you're going to feel like caca. Do you understand that one? Yeah, so if someone takes a glucagon shot, they're not going to be in much of a shape to do much of anything. They'll be conscious and everything, but it dumps all your liver glycogen and you just feel awful. So severe hypoglycemia, if the blood glucose drops to 20 mg per deciliter or below. Disoriented behavior and loss of consciousness. You'll have trouble rousing them unless you raise their blood sugar. If you don't raise their blood sugar, they can fall into a coma. They may start having seizures and they may die. And the risk of hypoglycemia is high in the elderly. Diabetics can carry, especially type 1s will have usually a pouch where they'll carry snacks. They'll usually have this, looks like a tube of toothpaste, but it's kind of honey colored. It's glucose goo. You can squirt some of that under their tongue. Under the tongue is very vascularized and they usually come to. That'll be enough for them to get up and be able to get something more substantial in their system. Do not make the mistake some of my brother's friends made where they gave a diabetic who passed out a shot of insulin. That will lower their blood glucose even more and it will kill them. They were hiking and this one person was diabetic and didn't bring anything with them and his blood sugar went really low. They didn't know what to do. They had great intentions. They gave him a shot of insulin. They killed him. Sometimes good intentions aren't enough. You have to know what to do. Patient education for sulfonylureas. The pills are not insulin. Pills are not insulin. They work with your body. They work with the insulin you already make. They're not insulin. Make sure your patient knows the signs and symptoms of hypoglycemia. Take it as prescribed. Know the name of the drug, know the dose. And see that bit that's underlined? Everybody read it to me. 1, 2, 3, read. Can't emphasize that enough. You can't come to someone and say, give me medicine and fix me. Nope, there's no fixing this. You have to manage this. You have to manage this. Questions about the insulin secretagogues? So the biguanides include metformin, first line for type 2 diabetes. Metformin does not stimulate insulin secretion. People didn't know how metformin worked for a long time. And then a paper came out about 6 years ago. Turns out it activates this enzyme in your liver called the AMP-dependent protein kinase. So it activates that particular protein kinase, and it increases the tendency of peripheral tissues to take up glucose. So it increases insulin sensitivity in those tissues. So it reduces the amount of glucose overall in the blood. Also, it inhibits gluconeogenesis in the liver. And third, it tends to diminish the intestinal absorption of glucose. You can lose weight on this drug. In fact, this drug is given as a weight loss medicine. It lowers fasting and postprandial glucose. Metformin does not cause hypoglycemia. And if you combine it with the sulfonylurea, which many endocrinologists will do, it tends to prevent the hypoglycemia caused by the sulfonylurea. Yeah, Erica, I know it's late. Do you guys worked out today? So you're tired? Oh, okay. How's it feel? Yeah, way better. Okay, so you're almost there then. Okay, see how that goes. Cool. Adverse effects of metformin. The biggie is it upsets people's stomach, but the extended release form tends not to, and that's usually the form that will be given. Is extended release form. Long-term use of metformin is linked to vitamin B12 deficiency. Therefore, individuals taking metformin should consider B12 supplementation. There's a rare side effect called lactic acidosis because the liver does not take lactic acid from muscle and convert it into glucose via gluconeogenesis. Lactic acid can build up, in the blood and cause acidosis. In people with normally functioning kidneys, this tends to not happen. But in people with some compromised renal function, this can happen. So metformin is contraindicated in people with renal impairment. It's also contraindicated in people with liver impairment, since it works in the liver. Contraindicated in people with alcoholism and conditions associated with tissue anoxia, such as heart failure, respiratory failure, or shock. Also, for those of you who will work in the ICU, you have to stop metformin treatment before you administer any intravenous iodinated contrast medium, because metformin will prevent the excretion of that contrast dye by the kidneys. And because the two are competing, metformin levels can increase, and metformin can then cause lactic acidosis. So you discontinue metformin, then you give the dye. Then when they're done with the imaging, you can restart the metformin. Yeah. Yeah. You have to wait because it takes about that long for the dye to work its way through. Provided normal renal function. And that algorithm is adjusted according to renal function. All right, this is a good time to take our break. So let's take 5 minutes and relax a bit, and then we'll reconvene. Oh, one more thing before we quit before the break, not quit for the night, but for the break. I have been doing battle with Blackboard for the last 2 weeks, trying to fill in the holes in some of your grades. I have not been completely successful. So if you have grades that are, you have the quiz in your files, let me know so I can fill that, fix that. Please don't come to me after finals week, after they submitted the grades and say, I should have gotten this grade because this wasn't in Blackboard because it got deleted, because Blackboard was deleting things front, left, and center. Please do it expeditiously. So before finals, you have a good idea of what your grade will be and so on and so forth and what have you. All right, can you do that for me? Please, cheers. All right, break, 5 minutes. Bless you.
Where she's living. Is she living?
Give me price.
That's fine.
Thank you. That's not funny. Yeah, Maddie rushed. Said, she said, we have flashes of brilliance. And we have flashes like, okay, this is high school. And she said, we just can't seem to have a good day. Well, no, actually, King versus Bethel tends to where a bunch of them get that grace. And then she quoted another one. The other game too, she said. So,
Yeah. No, it's a direct to Arizona.
Maddie said there are times where I smile.
I know, she's so she's good for breakdown.
I just feel like.
My theory is that somebody is going to know already from the outside.
Which,
I'm
past evidence, it's only been-
Yeah, there's been a lot of new coaches in our conference too, so a lot of the teams that were lower. not that high. So I think it was just more like. Get a bunch of. People.
You guys are right. It's the same principle that she says.
She's got a little bit better though, but she's very, very talented. Yeah, she's really good.
And I know she's been trying. What are your chances of making the playoffs?
But if we split since we were 1 year in the final grades and that affected split grades. We're in 8th grade now, with 3 split grades. But they play. So the chances are, I guess, if we could squeeze time, I will. So we have to make up. If you're in the top 11, so.
Yeah. I'm looking for a high five or.
No, I have a question.
Yeah.
So that everyone says tired of everything, the Jordan's and it's part of the deal.
No, no. Not you. Okay, okay. Great, thank you. Jess, you want to do it now? Can we do it? Can we do it after class? Is that okay? Because we need to get back on the horse here. All right, one more thing about metformin before we move on. Metformin can be combined with several other medications. It plays well with other anti-diabetic medications, so that's also one of the advantages of it. The alpha glucosidase inhibitors inhibit the brush border enzyme glucosidases that degrade oligosaccharides or disaccharides into monomers that the enterocytes of the small intestine absorb. Consequently, those oligo and polysaccharides will not be absorbed and they will go out with fecal material. This will delay glucose absorption and it can lower glucose of the blood in general. These medications are never used as monotherapies. They're not powerful enough. But if you have someone who just can't get their blood sugar below a certain level, these can actually tip it into that normal range. So there's acarbose and miglatol. Acarbose and miglatol. Biggest downside of these drugs, they're not absorbed systemically, so they don't have systemic side effects, but those oligosaccharides are fermented now by bacteria in the GI tract, so they can cause a good deal of gas. So flatulence is a big problem with these particular drugs. And don't give it with these particular caveats. It can make inflammatory bowel diseases, particularly Crohn's disease, a lot worse. Don't give it in people with diabetic ketoacidosis or cirrhosis, known hypersensitivities to the drug, chronic intestinal diseases, or renal insufficiency. Those are the alpha glucosidase inhibitors. Now we come to the thiazolidinediones. Thiazolidinediones. There are two medications in this group. There is rosiglitazone, which goes by the trade name Avandia. Rosiglitazone. And pioglitazone or Actos. So notice the ending glitazone, that's a TZD. These drugs are also insulin sensitizers. They have a relatively slow onset of action. They work as agonists of a transcription factor called the peroxisome proliferator activated receptor gamma, which is mercifully abbreviated PPAR gamma. These bind to PPAR gamma and they elicit changes in gene expression. So they bind DNA, they activate the transcription of genes involved in glucose and lipid metabolism. They increase insulin sensitivity in adipose tissue, liver, and skeletal muscle. They also increase the levels of a very important molecule called adiponectin. And adiponectin is an inhibitor of gluconeogenesis in the liver. Consequently, they will decrease blood glucose levels. Downside of these drugs is that they increase the synthesis of proteins involved in lipid metabolism. So they will decrease serum triglycerides, but they raise LDL levels. Now they raise HDL levels too, but that rise in LDL levels can be a problem. TZDs are not associated with hypoglycemia. They can cause some fluid retention, so they can make heart failure worse. They are associated with weight gain, and long-term use tends to associate them with loss of bone marrow density, bone density. So osteopenia is a potential issue. There was a report that they increase the risk of heart attacks. Further work has shown that that is not the case. Pioglitazone, long-term use, slightly increases the risk of bladder cancer. And rosiglitazone can slightly raise blood pressure because of the increased fluid retention. These also play well with other medicines. They can be combined with other medicines. Any questions about the TZDs? All right, we have now some drugs that have a somewhat new strategy. There's two medications. One of those medications is injected. The other is oral. So years ago, people made an observation that went like this. If you inject glucose into a laboratory animal, you get this much insulin that's made. If you feed them glucose, you get this much insulin that's made. Why that was the case was unknown for a long time. And then people discovered a group of peptides made by the L cells in the small intestine, and these molecules were collectively known as incretins. Incretins sensitize the pancreas to glucose. They increase the synthesis of insulin. They have a trophic effect also on the pancreas, which is potentially important because with type 2 diabetes, sometimes the beta cells can get burned out. They can actually die out, and now you become insulin dependent and a type 2 diabetic, which is a big drag. So these have a trophic effect on the pancreas, and drugs that bind to the receptors of incretins have been generated, and they are called GLP-1 receptor agonists. GLP-1 receptor agonists. This other group of drugs inhibit the enzyme that degrades incretins. This enzyme is called dipeptidyl peptidase 4, which is mercifully abbreviated DPP4. And these are the DPP4 inhibitors. So let's look at these particular medications. Notice that these drugs all end with gliptin. Gliptin. So there's sitagliptin, saxagliptin, linagliptin, and alogliptin. These drugs are not yet available as generics. So they are relatively expensive. People usually won't go on them unless they have insurance that pays for them. These medications are, on the average, well tolerated. Some of the side effects that you see in some people, and I went and looked up some of the studies that were done and got percentages of what some of these side effects are. You see, they're not terribly high, but they include GI disturbance in some people, headache, nasopharyngitis, mild urinary or respiratory infections. These drugs do not cause weight gain. These drugs are also excreted by the kidney, so you should not use them in people with renal failure. Now for the incretins. The granddaddy of the incretin group is exenatide. This was the first incretin that was made. It was made by Eli Lilly Corporation. You know how they discovered it? It's based on a compound from the venom of the Gila monster. Turned out there was a compound that would greatly, from the Gila monster, that would greatly reduce blood glucose levels. And based on that peptide, that's where exenatide came from. So medicines come from the strangest places sometimes. So these are injected subcutaneously. There is now an extended release form of exenatide called Byduron. And Byduron, you can see, is given once a week. And then there's a newer form of Byduron, Byduron Bice. That's also given once a week. These come in auto-injector pens and are injected sub-Q. The next incretin mimic to hit the market was liraglutide, goes by the trade name Victoza. Exenatide goes by the trade name Byetta. Liraglutide is also prescribed for weight loss. These drugs delay gastric emptying. Therefore, they cause satiety, increased satiety. You don't eat as much when you're on these drugs. So they're excellent for weight loss. This drug is given once a day, as opposed to exenatide, which tends to need to be given twice a day. Then there are the incretin mimics that have long half-lives. So there's these two medications, dulaglutide, that goes by the trade name Trulicity, and semaglutide, which goes by the trade name Ozempic. If you've been in the gym, you've seen the advertisements for these on ESPN. These are given once a week. Very convenient. Rarely, these drugs can cause pancreatitis. There is a black box warning for increased risk of thyroid cancer as well. Albeit it seems from post-marketing research, the risk of thyroid cancer is not terribly high. But it has been reported. It's difficult to know if the drug is the reason for it, but FDA wanted the black box warning all the same. Because of the tendency for the stomach not to empty, some people have a feeling of being full pretty constantly. Victoza can plug some people up to some extent, so increase fiber intake and what have you. Some people say it makes them jittery and they get headaches. On the average, the most commonly reported side effect is reactions at the injection site. Some people experience fatigue on these drugs, but that tends to be short-lived. And then we have the SGLT2 inhibitors. These are quite new. Notice they end with gliflozin. Bless you, gliflozin. Canagliflozin, that's the oldest member of this group. Dapagliflozin, empagliflozin, and ertugliflozin. Invokana, Farxiga, Jardiance, and Stelgatro. Stelgatro, sorry. These can sometimes drop the glucose level like a rock. You have increased risk of UTIs with these drugs because you have sugar going out of the urine. Now, these drugs also are being used for people with heart failure. And the FDA has now approved dapagliflozin and empagliflozin for people with heart failure, whether or not they have diabetes, because it reduces hospitalization, death, and improves symptoms so much. Allergies to these drugs have been reported. So watch for things like rash, hives, itching, difficulty swallowing, swelling of the face, blah, 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 that sort of thing. Also, it's really important that people hydrate with these drugs because you'll lose a fair amount of water. And you'll lose a fair amount of sodium because it inhibits the sodium glucose cotransporter. And in older people, since hyponatremia can be a problem in older people, increasing their sodium intake will be important. And usually saltine crackers can fix that. We had soup. My kids used to take the saltine crackers and lick the salt off and then throw the cracker away. What am I raising? They don't do that anymore. Yeah, we talked about the Tarman. Yeah. Now, semaglutide has an oral formulation now called Rybelsus. This is the first oral incretin. So it works as well as the injected incretins, but you take it essentially before meals. It can delay the absorption of other drugs. So you have to time when you take it. But Rybelsus, for people who don't want to give themselves injections, can be a remarkably effective medication. Any questions about any of these medications before we move to the insulins? All the insulins that are available today are from genetically engineered microbes. Pork and cow insulin, Eli Lilly stopped making the pork insulin in 2002. Cow insulin was discontinued in a little bit before that. All the animal insulins has been discontinued. It's all human insulins now. Insulin is used to treat diabetes. It can also be used to treat hyperkalemia. Because with the activation of the uptake of glucose comes the uptake of potassium. So if hyperkalemia, you can also use insulin to treat that as well. So the sources of insulin are genetically engineered microbes. White people have a problem with genetically engineered food, but they don't have a problem with insulin from genetically engineered organisms. I can't explain that, but that's the way we are. We have people who get glued to technology all day. We even use the term screenagers for people in that range who sit at the dinner table and, blah, 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 and all this. And yet when it comes to food from genetically engineered organisms, we have this, this unique freak out. I honestly don't get it, but there are a lot of things I'm not smart enough to understand because I'm frankly not that smart. So use for diabetes, use for hyperkalemia. So side effects, big one, hypoglycemia. A little bit about insulin. Insulin forms groups of 6 hexamers. The insulin monomers like each other. And so they go hug, essentially. They're like a bunch of nursing students on before a test. They just group together and they just want to stay together so badly. So if you inject insulin underneath the skin, sub-Q, those hexamers have to dissociate first. Then the monomers get absorbed. That delays the absorption of insulin. So here is an insulin hexamer. You see groups of three. Each of those groups of three are dimers. This is a crystal structure. So what the drug companies did, they actually made the first one by mistake. If you put mutations in insulin so they can't make hexamers, they get absorbed really fast. And those are the rapid acting insulins. They're genetically engineered to not form hexamers. These are the insulins that are used in pumps. So this includes Humalog, Novolog, Apidra, Fiasp, all those types of insulins and what have you. These are short acting. You give them usually about 15 minutes before you eat a meal. They start acting usually within 20 minutes. They usually will work for they peak about 40 minutes-ish after you've given them. And then usually by an hour and a half to 2 hours, they're done. And you can see this here essentially with the profile of their activity, essentially. Okay, sorry, that's a regular insulin. So the regular insulin peaks 2.5 to 5 hours, has a duration of activity 4 to 24 hours. Onset's usually about 30 minutes-ish, but it takes a while to peak. That's regular insulin. The rapid acting insulin doesn't make the dimers. So it gets absorbed really quickly. So that's the Apidra, insulin glulisine, insulin aspart, that's Humalog, and then Lispro, that is Novolog. All the other insulins are usually variations on a theme. So regular insulin forms hexamers, rapid acting insulin does not. And that's what's used in pumps. Used to be, you only gave regular insulin intravenously. Now, with enough research, it's clear you can give the rapid acting insulins intravenously as well. Those are the only two you can give intravenously. Rapid acting or regular. You don't give the intermediate acting or the mixed or the what have you. Intermediate acting insulin. So these are complexed with protamine salts. Oh, protamine, the thing that's used to counteract heparin? Yep. Same molecule. You form a complex, so now you inject it, the protamine needs to dissociate, and then the hexamers need to dissociate, and then they're absorbed. That delays the onset of activity. So NPH is the neutral protamine Hagedorn. There are different brands of NPH. Lenti was discontinued, not used anymore. So this, as you can see, usually will start working about 2 hours. It peaks usually 4 hours-ish, and then it'll usually last 24 hours. So this gets used more for type 2 diabetics. Type 1s with pumps aren't using a lot of intermediate acting insulin. If you have glucose elevations, when the rapid acting ones stop working, intermediates can get rid of that. Then you have the peakless insulins. Peakless insulins. So these are meant to provide basal level insulin, not the big bolus of insulin you need after you eat, basal level that you kind of always need. The peakless insulins are being used by type 2 diabetics with pumps again. You're seeing type 1 diabetics really not using the long-acting insulins very much at all. So these still have a market. So Lantus is the granddaddy of this group. With this, you have this is in an acidic buffer. You get little crystals that form, and then those crystals very slowly dissolve and release the insulin that is absorbed sub-Q. Because of the acidic buffer, some people, when they inject Lantus, it really irritates their skin. So some people really don't like Lantus for that reason. Other people really get good control with it. Basaglar is another formulation of Lantus that's actually quite inexpensive. So here you have a comparison of NPH versus Lantus. Do you see a peak there with the Lantus? Nope, just kind of slow and steady wins the race. Oh, do, 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 do. And notice that can give you the insulin you need before you go to bed. So a shot of Lantus can last 24 hours. Erica? No, no. That in fact was the way most diabetics did it before the advent of pumps. So because the pancreas kind of secretes a low level of insulin, the Lantus is kind of a low level, and then the bolus, the fast acting regular or rapid acting, that gives you the bolus after you eat. So the Lantus essentially was the support, and the bolus that you needed was the injected one. So you can use them both just fine. And in fact, type 2 diabetics will use both often. In fact, Miss Jessica works at the Oaks, and have you given any Lantus shots to that resident? What's her name? I don't remember her name, but my wife. Well, you adjust the injector. She can't see very well, so you adjust the injector and you give it to her, and she injects herself. Oh, she's not still on it. Oh, okay. Oh, okay. Because Lantus can be so irritating, drug companies have developed some new long-acting insulins that don't require the low pH buffer. So the Gludec is Tresiba. This particular insulin will bind to serum albumin and then will very slowly get released. So your release is not so much a function of absorption, it's a function of it being released by serum albumin. And then Detamir, which goes by the trade name Levemir, this one has a lipid group attached to it. And that lipid group attached to it causes it to be bound by serum proteins and then very slowly released. Now, this drug turned out to be a bit of a disappointment. Turns out you probably have to give yourself 2 shots of that one per day. But the Glutec, as you can see, can last up to 42 hours. It's very long lasting. Now, there are some things that you have to be aware of when you're talking about type 1 diabetics and giving them self-insulin at night. Keep in mind that during the night, your pituitary releases growth hormone. What does growth hormone do to sugar? Somebody look at me like it's too late to remember that long ago. It raises it. It prevents glucose uptake by cells. it spares glucose for the brain. So if your growth hormone release at night, and this is particularly acute in kids. Adults don't have so much growth hormone release, they have a little, very little. But kids have more growth hormone release. This will tend to raise your blood glucose level at night. So you go to bed, essentially here, you wake up, now you're here. But I didn't eat anything. It's because of that growth hormone. That growth hormone. So that is called the dawn effect, the dawn phenomenon. And it usually occurs between 4 to 8 a.m. To fix this, just increase your insulin dose at bedtime. Then there is a rebound hyperglycemia in response to nocturnal hypoglycemia. That is called the Somogyi effect. If this is the case, decrease your nighttime NPH. If you hear yourself NPH at night, just decrease the dose. That usually should fix that. Somogyi effect is usually due to excessive insulin. Alcohol can cause it too, so can a missed meal. Because during the night, the body will release epinephrine and cortisol and glucagon, and that can cause high morning glucose levels. So if you have a protein-rich snack before bed and reduce your evening insulin, that can usually fix that. In addition to insulin, the beta cells also make a peptide called amylin. When amylin was discovered, most medical researchers said, so what? Doesn't seem to do anything. What's the point? And then people started combining amylin with insulin. And it turns out that amylin increases satiety, and it can actually increase insulin efficiency. So now it's not uncommon for people who use insulin to also inject amylin. So this is used a lot in type 2 diabetics. The trade name of this drug is pramlintide. It can cause some stomach upset, some headache, dizziness, abdominal pain, fatigue, coughing, allergic reactions, joint pain. These are not common side effects, but they've been reported. It's usually pretty well tolerated. There is a black box warning for severe hypoglycemia. So it regulates glucose by slowing the rate of gastric emptying, suppressing post-meal glucagon secretion, and reducing food intake in general. It's deficient in type 1 diabetics and relatively deficient in type 2 diabetics. All right. When people take insulin, if they have a pump, one thing they must be taught to do is to make sure they don't reuse their tubing, because the tubing can get plugged. Also, the tubing can grow things. Imagine having that in your body. No. So the tubing, usually they'll be given a roll of tubing. They need to make sure that they are replacing the tubing. Also, when they handle the tubing, they need to make sure they handle the tubing with either very clean hands or with gloves. It's very important if you're using a pump that you alternate where you put the pump, where you put the insert for the pump, because insulin will tend to cause something called lipodystrophy. So you get a little fat pad, and that's due to insulin essentially inducing fat synthesis. If you leave it in that place too long, that fat pad gets big and it can get hard and it gets scarred over. So make sure you rotate where the pump sub-Q needle is placed. And make sure the blood sugar is monitored on a regular basis. That's very important. Now with CGM, excuse me, that's really very easy to do. All right, I am going to save this for Monday of next week. We will finish this and move on to the next thing. Don't forget to check your grades. There will be no ATI tomorrow because I'm going to Pinnacle tomorrow with the HES students to do human cadaver dissection. I'm very excited. Just hope I get enough sleep tonight, so I'm worth it. Sorry? Yeah, if you contact Mindy, email her and ask her, and I'll email her. And, oh, cheers. And, yeah,